Hello, everybody. My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation Educational Series webinar. This evening, we're going to be talking about counseling patients with moderate to severe atopic dermatitis. Our moderator this evening is Dr. Firouzeh George Houjier, who is Clinical Assistant Professor, Department of Internal Medicine, Philadelphia College of Osteopathic Medicine, and President of Southeast Dermatology Specialists, Research Director of Southeast Research Specialists. Our guest speaker this evening is Dr. Lisa Swanson, who is from IDEF West Dermatology and St. Luke's Children's Hospital in Meridian, Idaho. We'd like to thank our supporter, Pfizer, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the information will be displayed. If you're having technical issues, or if you would like to ask a question to our faculty, please ask a question in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in the browser and we will be emailed to you within 1 to 2 days. We'd greatly appreciate it if you could send it back to us. And within 1 to 2 days of the webinar, our certificate of attendance will be sent to you. Again, if you want to submit your questions, please submit your question in the question chat pane on the right-hand side of your screen, and I wrote a little note there so you can see exactly where you need to type it. So without further ado, I will pass the floor virtually to Dr. Houjier.
Thank you. Yep. Thank you very much, Roxanne. It's a pleasure to be here today again for another IDEF webinar. The IDEF is an organization that was founded by Dr. Leon Kircik. It is a nonprofit organization whose principal mission is to raise awareness and improve dermatologic care all over the world through education, and especially in the underserved areas. Many educational sessions were promoted and organized by the IDEF, including many of the ones you see here with great speakers, Dr. James Arasso, Dr. Brittany Craiglow, and others. And today is no different. Stay up to date with the IDEF Educational Series webinars on Instagram, on LinkedIn, or on Facebook. There's also a website to register at upcoming educational events. That's the IDEF Educational Series.com. Please do so if that is of any interest. But without further ado, today we have Dr. Lisa Swanson, who's a pediatric dermatologist in Boise, Idaho, who will discuss with us the counseling of a patient with moderate to severe atopic dermatitis. Dr. Swanson?
Hello, thank you so much, Firoz. Hello, everybody. Thrilled to be here. Lisa Swanson, dermatologist, pediatric dermatologist, Boise, Idaho, land of potatoes. Thrilled that you guys are tuning in tonight. I realize that there are lots of other things you could be doing. You could be decorating for the holidays. You could be crying about the end of the Eras Tour. That's what I was doing yesterday. You could be binge watching Chimp Crazy on Netflix. So there's lots of things that you could be doing tonight, and instead you're tuning in to our presentation on Transparent Talks about the treatment of atopic dermatitis. I think you made a good choice. We're going to make it worth your while. It's going to be awesome. We'll dive right on in. So in this talk, we're going to be talking about counseling a patient with moderate to severe atopic dermatitis, about treatment options available to them, about when to consider a switch in treatment, and when to consider a JAK inhibitor for their treatment. And I think you're going to learn a lot, and I think you're going to have a great time. It has quickly become a pretty awesome time to be practicing dermatology and treating patients with atopic dermatitis. Wouldn't you say, you guys? I mean, 7.5 years ago, treating bad atopic dermatitis really stunk. It really sucked. You know, I have become a bit known for saying that before we had some of these wonderful therapeutic options to choose from, picking a systemic agent to treat bad atopic dermatitis was like picking a porta potty out of a row of porta potties. You know they're all gonna suck, but you gotta pick one when you have to go. I was never excited to put a patient on methotrexate or cyclosporin. I did it out of desperation because I had no idea how else to help them. And now We don't have to pick a porta potty anymore, you guys. We have all of these wonderful choices to choose from. Anybody out there a fan of The Golden Bachelorette? I am, big fan. You can binge watch the entire season on Hulu if you missed it. It's really fantastic. But in the opening episode, our Golden Bachelorette, Joan, comes and meets her 25 suitors. And at the end of the cocktail party, one of those suitors, his name's Kim, he's a retired Navy captain, says to the camera, he says, you know, Joan has a really tough decision in front of her because there is no shortage of stallions in the stable from which to choose. What? That can't be the first time that he said that sentence. That cannot be the first time he said those words. But we are quickly getting to a point where there are no shortage of stallions in the stable from which to choose for the treatment of moderate to severe atopic dermatitis. And that is a pretty great situation to find ourselves in. So we have a lot to talk about with our patients. We have a lot to talk about during our presentation tonight. Here is our disclosure slide. I'm here, of course, on behalf of Pfizer. I'm presenting this slide deck that's been created in accordance with FDA prescribing guidelines. One of the ways you're going to know that I did not create this slide deck is that you will not see any pictures of my doggies during this presentation. And if I had created this slide deck, there would definitely be pictures of my doggies. And if afterwards you want to see pictures of my doggies, I would be happy to show them to you. I bet I could put my phone up there and give you a little glimpse of my two little angels, Mosby and Maggie. I would love to share their cute little faces with you guys. We'll start out with important safety information, and initially we go over the official indication for Sabinco. So Sabinco is indicated for the treatment of adult and pediatric patients aged 12 and up with moderate to severe atopic dermatitis whose disease is not adequately controlled with other systemic drug products, including biologics, or when use of those therapies is inadvisable. So you're looking for patients who are 12 and up, who have bad atopic dermatitis, who have failed other therapies, who are in need of something more. A limitation of use, not recommended for use in combination with other systemic therapies. And it has a boxed warning for serious infections, mortality, malignancy, MACE, and thrombosis. Did you guys know that the JAK inhibitors have a boxed warning? I bet you did. And we're going to talk a lot about it during the course of this presentation. We also have a brief contraindication here. So Sabinco is contraindicated in patients taking antiplatelet therapies except for low-dose baby aspirin during the first 3 months of treatment. Why? Well, a few patients developed thrombocytopenia during the first 3 months of treatment. So their platelets got a bit low. And if your platelets get a bit low, you want the platelets you have to be working at their utmost capacity. And so that is why these antiplatelet therapies, with the exception of baby aspirin, are not allowed during the first 3 months of treatment with Sabinco. So the American Academy of Dermatology recently updated the guidelines for the treatment of moderate to severe atopic dermatitis and now includes medicines like Sabinco. This was a huge update, you guys, that was made in 2023. And I think the last time these treatment guidelines for atopic dermatitis were updated, I think Gary, the Golden Bachelor, was actually in high school. Just kidding. It was like 10 years ago, but it feels like a billion years ago because so much has changed. The past 7.5 years have been amazing in the world of treating atopic dermatitis. And finally, we have some guidelines that reflect that. And they issue a strong recommendation for the treatment of atopic dermatitis with our oral JAK inhibitors as well as our biologics. They caution against the use of oral prednisone, and there's a mild support for systemic immunosuppressants, those porta potty treatments that I told you guys about. So we have strong recommendation for our biologics and for our JAK inhibitors, and it's really nice to have these guidelines out there. They can also be helpful when you're dealing with an insurance company and negotiating coverage of a medication to have those guidelines. So that's really good, and we're really happy to have them. So during this talk, we're going to cover a lot of stuff, and we're going to start with a little bit of JAK biology. You guys ready for a little bit of basic science? I know it's my favorite, she says very sarcastically. Basic science is not my thing, it's not my jam, but I make the best of it, and hopefully you're going to appreciate some of my analogies as I take you through the basic science. So JAKs are intracellular enzymes that are activated by cytokines upon binding to cell surface receptors. So basically what happens is these cytokines bind to their receptor, which activates the JAKs, which activates the STATs, which creates gene replication in the nucleus. And then you get more cytokines as a result, okay? Now, different cytokines trigger interaction with different JAKs. We've got 4 JAKs. We've got JAK 1, 2, 3, and TYK2. And so you can see here that different cytokines, where they bind, they interact with different JAKs on the other side of that cell surface receptor. So depending on what disease state is going on, depending on what disease state you want to try to thwart, you're going to try to interact preferentially with a particular JAK or 2. Now, it's really hard to be super specific with JAK inhibition, but a lot of our JAK inhibitors try or have preferences for certain JAKs so that we inhibit and decrease certain cytokines. So hopefully that helps make a little bit of sense. Looking into it further, so we have this cytokine that binds to the cytokine receptor, which activates the JAKs. I'm going to do a little clicking here. Activates the JAKs, which then activates the STATs, which then creates the creation of more cytokines. There's a lot of clicks here in the nucleus. I'm just going to accelerate my clicking. There's a lot of clicks. Okay, there you go. And so basically what happens is this one cytokine binds and it interacts through the JAK-STAT pathway, and then more cytokines are created, which helps drive these inflammatory processes. The way I think about it is if you think about a slot machine in Las Vegas, you put one coin in, and if you hit the jackpot, right, you get a lot of other coins out. If you inhibit the jackpot, you don't get all those coins and you don't get all those cytokines. So I told you my analogies were coming at you, and hopefully you are enjoying them. But that's how I make sense of the JAK-STAT pathway, the jackpot at a slot machine in Las Vegas. So now let's talk into a little bit of Sabinco and kind of an overview of Sabinco. We'll dive right on in. We know a little bit more about the JAK-STAT pathway now, and we know that certain cytokines play a crucial role in atopic dermatitis. IL-4 and IL-13, right? We've known about them for the past 7.5 years because of dupilumab. IL-22 is something that we hear about with increased lichenification, kind of psoriasiform atopic dermatitis. IL-31 is known as the master itch cytokine. Interferon gamma plays a bit of a role. And then TSLP, which I refer to as the itch scratch cytokine. So TSLP makes you itchy, and then when you scratch, it activates TSLP, creates more TSLP. So now it's a frenzy of TSLP. And so I refer to TSLP as the itch scratch cytokine. And all of these cytokines are working in different ways to impact the inflammatory process that is atopic dermatitis. And when I see these depictions of all these different cytokines, each one of them playing their own role, I can't help but think that they're a lot like the contestants on The Bachelor. You've got the crier, you've got the pot stirrer, you've got the girl that's there for the wrong reasons. You've got the girl with the heart of gold that just can't seem to find things that go her way. And each of them is contributing to the magic that is The Bachelor, just as each of these cytokines are contributing to the magic that is inflammation and atopic dermatitis. And all of these cytokines are working through the JAK-STAT pathway. So a great way to go after all of these cytokines in one fell swoop would be to inhibit the JAK-STAT pathway. Every time I say one fell swoop, I think of Nate Bargatze. He's a stand-up comedian. He has this great bit about one fell swoop. If anybody out there has not heard of Nate Bargatze, I have some homework for you tonight. He has 3 specials on Netflix. You got to download them. You got to watch them tonight. Your life will be changed. He's so funny. He's a clean comic, so you can watch him in the company of anybody. You can be watching it with your grandmother. You can be watching it with your dad. You can be watching it with your kids. Anybody can watch Nate Bargatze. Go ahead and watch that tonight. Treat yourself to some Nate Bargatze tonight, and you will thank me tomorrow. So how does Sabinco work? Well, it's an oral small molecule JAK inhibitor that works inside the cell to inhibit the JAK-STAT pathway, to inhibit this jackpot of cytokines, and therefore help reduce the inflammation of atopic dermatitis. That is Sabinco in a nutshell. Now, let's meet Anna. My first question for Anna would be, do you pronounce your name Anna like banana or Anna like frozen? Because that's an important question. So let's say she pronounces it like Anna like banana. And she's 37 years old and she has moderate to severe AD that's not well controlled, even with a biologic. So she moisturizes twice a day. Sensitive skincare still so important, even with the therapeutics we have. She uses topical calcineurin inhibitors. She uses topical corticosteroids. She uses an injectable biologic, but still she is struggling. She has persistent pruritus resulting in frequently scratching throughout the day, eczematous lesions on noticeable areas like her face, neck, arms, and her legs, 15% body surface area affected, IgA moderate, meaning 3. And so Anna, despite being on all of these treatments, she is really struggling with her atopic dermatitis. In fact, you could say that she is down bad with her atopic dermatitis. Don't know if there are any Swifties out there, but Down Bad is one of my 3 favorite songs from the new album, Tortured Poets Department. What are the other 2? Sure, I'll tell you. They are Fortnite and I Can Do It With a Broken Heart. And they're all magical and wonderful. And after you watch Nate Bargatze, you should go ahead and download those 3 songs and listen to them, and you will love them. And so Miss Anna here, she's on appropriate therapy. She's on all of it, but she is still struggling. Sometimes that's a little bit of a difficult conversation because I bet Anna would admit that she's doing a bit better than she was doing before she was on all these treatments. Her life is probably a little bit better. Clearly, she's still struggling, but she's made, I'm sure, some strides. And sometimes it can be a little bit of a challenge for a patient to want to take that leap to a different therapy, given that they have had some improvement on what they've been on. How can we help navigate that for them? You guys are going to learn some tips and tricks during this presentation about information you can share with them to help them in their decision-making process. And so hopefully you find that helpful. So how do I present JAK inhibitors to my patients, especially those who have already been on a biologic? I say these JAK inhibitors are awesome and have a really unrivaled ability to improve the inflammation of atopic dermatitis super, super quickly, especially when it comes to itch. These medicines work super fast to decrease itch, which is really the primary burden for our patients with atopic dermatitis. And so that's kind of my opening statement. I talk about the effect on itch. I talk about how quickly they work. And sometimes if it's a patient like Anna, who's already on a biologic, who is like, geez, Louise, I don't know if I feel comfortable making the switch. Sometimes I'll even offer to start with some samples of an oral JAK inhibitor. Here, give this a try for 2 weeks. Give this a try for a month. See what you think about it. See if you like it. And then if you like it, we can go ahead and make the switch officially. So sometimes I will throw that out there so they have a chance to experience the medicine. But I think also during this presentation, you're going to learn some data points, you're going to learn about its efficacy that I think will better prepare you to have that conversation with your patients too. So these were the structures of the pivotal trials when it came to Sabinco. So we had JADE Mono 1 and JADE Mono 2. These were the monotherapy trials, so no topical steroids, 12 weeks, Sabinco 100 versus 200 versus placebo. We had JADE Compare, a 16-week combination study that allowed the use of topical corticosteroids. These were just adults, 18 and up. Sabinco 100 versus 200 versus Dupixent as an active control versus double dummy placebo, oral injectable placebo. Now I know what you're thinking. You're thinking, ooh, goody, a head-to-head study between Sabinco and dupilumab. But no, hold your horses. That's not exactly the case. This study was not powered enough to be a head-to-head study between Sabinco and dupilumab. And I know what you're thinking. You're saying, but Lisa, it's called JADE Compare. Yes, I understand. But we need to resist the desire to compare because Dupixent was included simply as an active control, which is something that the FDA is wanting more and more these days. Then we had JADE Teen, a 12-week study in teenagers. We wanted to get more data in the teens. They were allowed to use topical corticosteroids, and they were randomized Sabinco 100 versus 200 versus placebo. And then patients from any of these studies could roll into JADE Extend, the ongoing long-term extension safety study, with the primary goal of looking at safety, but also paying attention to efficacy too. So that's a lay of the land when it comes to the pivotal trials for Cibinqo. Now let's get to some of the primary endpoints. This is looking at the co-primary endpoint of EASI-75 at week 12, monotherapy, again, no topical steroids, over 12 weeks. We see that 61% of the patients on 200 milligrams are achieving EASI-75, 40% on 100, 44% on 100 milligrams are achieving that success of EASI-75, and only 10% in the placebo group. And so pretty profound efficacy that is happening pretty darn rapidly. To put it into perspective for you, during the time it takes to watch a season of The Bachelor or The Bachelorette, that's 12 weeks, you guys. That's the journey to find love. We see nearly 2/3 of patients on 200 milligrams and almost half of patients on 100 milligrams achieving EASI-75. So a season of The Bachelor or Bachelorette is about 12 weeks. A season of the Golden Bachelor or Golden Bachelorette is only 8. Why shorter? Well, it's because they don't have a lot of time. They don't have a lot of time, you guys. They got to get in, get on, get done with it. They know what they want, and they're going to go after it. We also see here on the slide on the right-hand side the endpoint of IGA clear or almost clear. So we see the data from that at week 12 with Cibinqo 100, 28% of patients achieving that. Cibinqo 200, 38% of patients achieving that. Now, let's turn to the endpoint of itch improvement greater than or equal to 4 points at week 2 with monotherapy versus placebo from Jade Mono. So we're seeing at week 2, you guys, 11% of the patients on 100 milligrams are achieving that already, and 24% are achieving that on Cibinqo 200 milligrams just at week 2. From the time it takes to go from the fantasy suite to the after the final rose, 1/4 of patients on Cibinqo 200 milligrams are achieving this endpoint. Now, just a reminder about dose. When we're prescribing Cibinqo in the clinic, it's indicated to start with 100 milligrams a day and then advance to 200 milligrams a day if an inadequate response is seen. So in the trials, they were kind of comparing these two doses, but in real life, we start with 100 and then we proceed to 200 if an inadequate response is seen. So just to remind you of that. Now let's look at absolute change in itch from baseline over these 12 weeks. You see a remarkable reduction in itch in the Cibinqo 100 and 200 milligram groups, and you see that separate from placebo as early as 2 days. 2 days, you guys, these patients are noticing a difference, a decrease in their itch. Faster than you can binge watch all 3 seasons of Ted Lasso. These patients are noticing a reduction in their itch, their biggest burden when it comes to atopic dermatitis. That is highly meaningful. That is jacking fast. Now we see some pictures of a patient who was on Cibinqo 100 milligrams in mono 2, IGA 3 at baseline. We see week 2, dramatic improvement in the pictures, and at week 12, IGA 1 almost clear. Impressive visible improvement that you can see in these pictures that our patients would love to see on their own skin. Now let's talk about some endpoints from Jade Compare. Again, this was comparing Cibinqo 100 versus 200 versus double dummy placebo with the active control of dupilumab. This is looking at EASI-75 at week 12. Again, topical corticosteroids were allowed. And we see that at week 12, 68% on Cibinqo 100 are achieving EASI-75, 58% on Cibinqo 100 are achieving EASI-75. You see Dupi as the active comparator there, and then you see placebo down below, a little bit of a higher placebo response rate because, again, these patients were allowed to use topical corticosteroids. And I'll remind you, this was over just 12 weeks. So during the time it took Gary, the Golden Bachelor, to meet the second love of his life, Teresa, get married in a beautiful ceremony that was broadcast on television, and then get divorced. We see that 6 out of 10 patients on Cibinqo 100 are able to achieve EASI-75, and nearly 70% on Cibinqo 200 are achieving that endpoint. Really remarkable success. Looking at IGA clear or almost clear from Jade Compare, we see nearly half of the patients on Cibinqo 100 and about 1/3 of the patients, nearly half the patients on Cibinqo 200 and about 1/3 of patients on Cibinqo 100 are achieving the endpoint of clear or almost clear skin at week 12 with the allowed use of topical corticosteroids versus placebo. So really dramatic efficacy visualized here. Now let's talk a little bit more about itch. This is looking at itch improvement greater than or equal to 4 points at week 2 from JADE Compare. So we see 14% of patients on Sabinco 100 are achieving this clinically meaningful improvement in itch, 30% on Sabinco 200, 8% on placebo, and 13% in the active control of Dupy. So really remarkable itch improvement after just 2 weeks, after only a fortnight. You guys, you Swifties out there, I see you. After only a fortnight, we see remarkable improvement in itch for our patients with atopic dermatitis. And again, that is their biggest burden. So now, is there any more to know? That seemed like a lot of information. I learned a lot just there. Is there anything else to know about Sabinco? You bet there is. You bet there is. We're going to dive deeper and we're going to learn more because we're going to learn about JADE Extend. So JADE Extend is an ongoing long-term extension safety study that again was primarily looking at safety, but also looking at efficacy too. And so we're going to get to see some of the data from JADE Extend. A quick comment on the structure of JADE Extend. You remember that anybody from one of the previous studies, the previous JADEs, could roll into JADE Extend. This includes patients from JADE Compare. And this includes patients from JADE Compare who were in the Dupy active control arm for the first 12 weeks. So wouldn't it be interesting to look at the patients who were in the Dupy active control arm, who hadn't achieved success on Dupy, and see how they do when they roll into JADE Extend and they're guaranteed to get Sabinco, right? Wouldn't that be interesting? And very real life. Because honestly, if you have been seeing patients with atopic dermatitis, with moderate to severe atopic dermatitis over the past 7.5 years, chances are you've prescribed Dupy. So this is very real life to see a Dupy subresponder. How do they do on Sabinco? So we see here that patients who were defined as Dupy non-responders, there were 51 patients that hadn't achieved EASI-75. There were 105 patients that hadn't achieved EASI-90, and there were 107 patients that haven't achieved IGA clear, almost clear on Dupy. Now, these Dupy non-responders, or actually all of the Dupy patients, were put into oral placebo for a 4-week washout and then started on Sabinco, randomized to receive either 100 or 200. So that's kind of a structure of how they rolled into there. And this is going to give us a lot of really great information. But we do have to understand that with post hoc analyses, there are some limitations and biases. One of the biggest is that once you roll into JADE Extend, you are certain you're getting drug. You're certain you're getting Sabinco at that point in time. So there are some limitations and biases with this, but still gives us good, I think, very real life applicable data to help us make therapeutic decisions with our patients. So this is looking at EASI-75 at week 12 in JADE Extend in Dupy non-responders, patients who weren't able to achieve EASI-75 on Dupy. How many of them achieved EASI-75 on Sabinco? 68% of the ones on Sabinco 100 achieved that. 80% of the patients on 200 milligrams achieved that. So these were patients not able to achieve this successful mile marker on Dupy, able to do so on Sabinco. That's huge, right? So you guys know when you're like, you're into club, you know, and you're dancing and the DJ is like spinning the beats. I think that's what it's called. He's got the big earmuffs on. He's spinning the beats. And then like you can feel the momentum is like building and building and building. And then the DJ kind of drops it and then it's like, boom. And the crowd goes, whoa. And everybody's jumping. And it's like that drop the beat moment. This is that moment, you guys. This is that moment. Dupy non-responders switched to Sabinco do really, really well. And that is incredibly real life applicable. This is looking at IGA clear, almost clear in patients who were not able to achieve that on Dupy. You can see 1/3 of them on Sabinco 100 and 1/2 of them on Sabinco 200 are able to achieve IGA clear, almost clear skin at week 12 after being switched to Sabinco. So really remarkable there. Oh boy, I should have warned you guys. I should have warned you that the important safety consideration slide was coming at you. And I think the font here is like 5, it's very small. But I'm gonna take you through it and it's gonna be easy peasy. Whenever I get to the boxed warning slide in a JAK inhibitor presentation, I hear Taylor Swift's sweet voice in the back of my mind saying, it's me, hi, I'm the problem, it's me. because these medicines would be flying off the shelves like Ozempic if it weren't for this box warning that gives everybody a moment of pause. Because these medicines offer life-changing possibilities for our patients dealing with chronic inflammatory skin disease that have been notoriously difficult to manage through the years. And finally, we have these agents that can really change lives, and everybody kind of pumps the brakes a little bit because of the box warning. But we're going to dive into it during this presentation, you guys, and I think afterwards you're going to feel really refreshed. So it's not going to be a bad, boring talk about the box warning. You're going to learn a lot and you're going to feel refreshed and rejuvenated, I think. So where did the box warning come from? I think everybody knows this at this point. It was a tofacitinib study for RA patients who were all older than 50 with at least one cardiovascular risk factor. They were all also on methotrexate, and 57% of them were on prednisone. And it was a study demanded by the FDA and driven to see these potential endpoints. They were really assessing it to try to see if some of these safety issues existed. And so the study actually couldn't complete until some of these things were seen. And as a result of this trial, all of the JAK inhibitors, the entire family, was given the box warning. We are going to look at some pooled safety analysis from JADE Extend. And there are some biases and limitations when you're looking at pooled safety. And so that's important to understand. But still, I think this information will offer a lot of good information that you can take to your patients during discussion of the safety profile of oral JAK inhibition. So this is looking at the studied safety profile in 3,800 patients representing more than 5,000 patient years of exposure. That's a big pool of patients. And this is looking at safety events of special interest. So we see serious infections, zoster, malignancy, non-melanoma skin cancer, MACE, PE, DVT. So we see some of these numbers here. What do we really make of this? Well, first of all, we do see a bit of zoster. That's real. That has to do with the inhibition of interferon gamma. We see that increased risk of zoster, and we see that it's dose dependent. It's higher in the 200 milligram group. But otherwise, you're looking at these things, and you're like, geez, these numbers seem kind of small. I'm not sure what to make of them. How do I put some perspective on this? I'm going to show you some perspective in just a couple more slides. So wait for it. It's going to be legendary. Or I botched it. On How I Met Your Mother, Barney Stinson would always say, it's going to be legend, wait for it, dairy. And so we will get to some perspective in just a moment. These were the most common adverse reactions in patients taking Sabinco in the placebo-controlled trials for up to 16 weeks. So what do we make of this? This is a big table. So a couple things that kind of scream out to me. First, tummy stuff. So we see nausea, we see vomiting, we see upper abdominal pain and abdominal discomfort. It's common to see maybe a little bit of tummy upset with these oral JAKs. I encourage my patients to take with food to help reduce that. We see a little bit of herpes simplex. We know that. And that also has to do with the inhibition of interferon gamma. So we know we're going to see a little bit of HSV with an oral JAK inhibitor. Increased blood CPK. This was seen in the trials of all the JAK inhibitors. A few patients had increased blood CPK. It was never found to be clinically significant or relevant, and so it's not part of the indicated laboratory panel. So you don't have to check CPK. You could if you wanted to, but you don't have to check it. And then acne, JAKne. And so some patients on oral JAK inhibitors will develop a little bit of acne. That's okay. We're in derm. We can handle that. And then on the bottom of the second page, we see zoster. We've already discussed that. Thrombocytopenia. You can see 9 patients on Sabinco 100, or I'm sorry, Sabinco 200. And that is why the antiplatelet therapies, with the exception of baby aspirin, are contraindicated the first 3 months of treatment. The thrombocytopenia for those patients did self-correct over time, so that's why they're only contraindicated those first 3 months of treatment. So now, let's talk about putting some perspective to the AEs of special interest. How are we going to get that perspective? What we're going to do is we're going to kind of compare a randomized clinical trial data and real-world observational studies. Okay, now these are 2 different types of studies and trials with different characteristics, different designs, different pros, different cons. They're different. And so really directly comparing it, probably not the 100% right thing to do, but if you're like, I'm gonna live on the edge and I'm gonna compare these randomized clinical trial data and these real world observational studies, I think you can actually gain a lot of knowledge by doing so. But anytime you compare two different types of studies, you just need to keep that into perspective. The way I see it, it's kind of like comparing The Bachelor and Bachelor in Paradise, right? Like they're different. They're different. They have different pros, different cons, different styles of show, different, different ways of doing things, but they're both magical and they're both wonderful, and you want to appreciate both of them. And you might feel like, oh, maybe I want to compare them and say which one is better, but you wouldn't really want to do that. You just want to appreciate both of them and get a sense for both of them at the same time, which is what we're going to do here. So on the top, we see select AEs in patients taking Cibinqo in clinical trials. Cibinqo 100 and 200 milligram doses, MACE, VTE, malignancy. You see the numbers, you see the incident rate per 100 patient years, right? Then below, you see a retrospective study of a demographically matched cohort of patients with atopic dermatitis from Kaiser 2007 to 2018, and you see MACE, VTE, and malignancy rates. I'll let that data just kind of sink in for a moment. Let that just kind of get absorbed. Because if you look at these numbers, and of course it's wrong to completely 100% compare because these are different types of trials and studies, but the rates look pretty similar. So hopefully that helps give you guys some perspective on these AEs of special interest. So now, turning our attention to transparent talks and being able to talk to our patients and their families about considering an oral JAK inhibitor. How do I do it in clinic? Well, this was something that I had to kind of work on because when the JAK inhibitors came out and they had this box warning, it was like, how do I thoroughly yet efficiently go through the box warning in clinic with patients? How do I describe the safety profile of these drugs in a thorough yet efficient way that's not going to bog down my clinic and not going to overwhelm or scare the patient? And I had a lot of rough drafts. I'll tell you guys that, a lot of rough drafts. And can't you tell when things just aren't soaking in very well? The patient's face is kind of like deer in headlights. So I had a lot of rough drafts that didn't go well. But I finally come to a spiel that I'm comfortable with and that I use daily in the clinic that I think could be helpful to you guys. So I say to the patients and their family, I say, these medications are wonderful and offer unbelievable abilities to change lives for disease states that have been notoriously difficult to treat, like atopic dermatitis and alopecia areata and vitiligo. These JAK inhibitors are the future for these conditions. But they have a little bit of safety baggage that I can sum up in 3 things. Thing number 1, we do have to do blood work for these oral JAK inhibitors. Thing number 2, there is an increased risk of certain viruses on oral JAK inhibitors, like the cold sore virus and shingles. Do you have a history of cold sores? Would you like to be vaccinated for the shingles? The indication for the shingles vaccine is 50 and up, or 19 and up and on an immunosuppressing medication, and an oral JAK counts. Thing number 3, these medications have a box warning on them that stems from a study using a different oral JAK inhibitor called Xeljanz in a different patient population, patients with rheumatoid arthritis, who were all older than 50 years old, who had at least one cardiovascular risk factor, who were all also on methotrexate, and 57% of them were on prednisone. And because of safety concerns from those trials, the FDA thought it prudent to put the warning on all JAK inhibitors, including Cibinqo. I've reviewed your past medical history. I've reviewed your medication list. And I think the benefits of the drug far outweigh the risks. And that's how I do it. That's how I put it out there. And I find it gets the pertinent information out there in an easy to absorb sort of way and doesn't bog me down too much as I'm trying to work my way through a busy clinic. So hopefully you guys find that helpful as well. So we want to pay attention to doing our proper evaluation and monitoring for our patients with oral JAK inhibitors. We need to screen for infections before we start. Like I do hepatitis B, hepatitis C, quantiferon gold. We need to do some baseline labs. I do CBC, CMP, lipids. And then we want to periodically recheck CBC, CMP, lipids. at a protocol that you guys feel comfortable with. Because I think if you ask 10 different dermatologists how exactly they're doing this lab protocol, you'd get 10 slightly different answers. We're all doing the same general thing, but slightly different ways, slightly different intervals. I think do what you feel comfortable with, especially if you're new to JAK prescribing. Do what you feel comfortable with as you kind of dip your feet in the pond of JAK inhibition. Encourage your patients to catch up on any immunizations that they're due for, discuss the shingles vaccine, and evaluate for any history of blood clots, MACE events, any history of malignancy, any history of smoking, past or present. Those things are pretty important, and consider doing skin checks annually, which you're probably doing anyway because you're out there in derm, practicing derm. But we want to keep mindful of all of these various things as we're managing our patients with oral JAK inhibitors. This is the recommended dose. Again, as I mentioned before, start with 100 milligrams a day. You can advance to 200 milligrams a day if an inadequate response is seen. And so you can feel free to increase if it's not improving the way you would like it to, which is nice to have that freedom to increase for those who need it. Additional important safety information. So we should check baseline labs, especially with regards to renal status and hepatic status. So we know if the medicine is appropriate for them, if they're safe to take the medicine, if we need to do a dose adjustment because of some history of kidney or liver issues. So very important to get those baseline labs. Use in pregnancy is not recommended. And so you do want to talk to your families, your patients and their family about their family planning goals. Are they thinking about having kids anytime soon? Are they a female of childbearing potential? And this is something that's on their radar because that's something that's important to know. Drug interactions, you do want to go ahead and get out your Epocrates app and type in the patient's list of medicines along with Sabinco and just see if there are any interactions. I would much rather lean on my Epocrates app and try to memorize which CYP, blah, blah, blah. That's too hard for me to remember because I have too much space in my brain reserved for Taylor Swift lyrics and Bachelor stories and anecdotes. So I use my Epocrates app for those things. And then lactation, in addition to not being recommended during pregnancy, it's not recommended to use during breastfeeding as well. So basic information there. This is our summary slide. You guys were nearly there. So Sabinco is proven to offer powerful skin clearance, rapid itch relief, and the flexibility to increase the dose if needed in patients 12 and up. It's a small molecule JAK inhibitor that works inside the cell, flexibility to increase the dose, a once daily pill, powerful skin clearance with meaningful itch reduction, fast, and well studied in 3,800 patients representing more than 5,000 patient years of exposure. And again, the indication 12 and up, moderate to severe atopic dermatitis in patients who have failed other things. And there are additional resources available online for both you and for your patients. Feel free to scan the QR code for these additional resources if you'd like. There are also more transparent talk videos on the internet, so you can scan the QR code. You've seen me talk about transparent talks. Why don't you go ahead and listen to Dr. Aaron Farberg or Dr. James Song and see how they do it and how they communicate with their patients about the power of JAK inhibition. So these things are available online if you'd like to watch them. And then this brings us to our thank you slide. And of course, I'd be happy to take questions if there are any. The one other thing that I like to kind of throw out there, you know, the JAK inhibitors, they have this box warning. We know that. We've heard about it. We've talked about it. I hope the data presented tonight really helps you. And it occurred to me the other day that, like, really, this box warning on the JAK inhibitors is kind of like a big Bernie doodle. A big 150-pound Bernie doodle that you see from a distance. And it's barking, and it's jumping, and it's pulling on its owner's leash. And from a distance, it's kind of scary. It seems like a ferocious beast. But then you get up close to the Bernie doodle, and you pet the Bernie doodle, and you snuggle the Bernie doodle, and you kiss the Bernie doodle, and you realize this isn't scary. It just looked scary from far away. So I encourage all of you, the next time you're thinking about the box warning, to think about a 150-pound Bernie doodle. And hopefully that serves you well. Thank you again so much for tuning in. Happy to take any questions. I actually deleted my chat box because it was in the way of my screen. And so if there are any questions, please have somebody read them to me, Roxanne or Faraz, if there are any questions. Otherwise, I will sign off and wish you adieu.
Lisa, thank you very much for a great presentation. There are a few questions that came in.
Okay.
One of them is, at what age do you advise shingle vaccine if on Sabinco? Do you in fact advise them to get it?
So the official indication for the vaccination for shingles is 50 and up, or 19 and up on an immunosuppressing medication, and an oral JAK inhibitor does count. So anybody 19 and up who's thinking about going on a JAK would have the ability to go ahead and get vaccinated for the shingles. I mention it to folks, I encourage it. I practice in Idaho. There aren't a ton of people just running out there to get vaccines here in the potato state. But I do mention it, and I do mention the increased risk of shingles, and I put it out there and I see what comes back at me.
All right, wonderful. And what do you do with teens or women on birth control pills? Is this something that worries you?
Yes. So in these studies on oral JAK inhibitors for atopic dermatitis, there were a lot of females on birth control pills. In the Sabinco trials, I feel like it was 15 or 16% of the female patients were on an oral contraceptive. There were no DVT or venothromboembolic events in any of the females on a birth control pill. And so I would actually much rather have a female of childbearing potential on a birth control pill with their oral JAK inhibitor than not. So I feel comfortable with it.
And last question, who do you pick for a JAK inhibitor as a best option?
That is so tough. And I think we're so lucky to have all these choices. We're so lucky to have all these stallions in the stable from which to choose, because it's really, really nice to have all these options. I think both Sabinco and Rinvoq are both good medications. Some of the decision making, unfortunately, comes down to insurance. Insurance companies, sometimes they have a preference for us. Sometimes it depends on what I have samples of in my samples cupboard, because I really like to start my patients on samples that day. I'll give them the first month of medicine. I'll say, go out and get your baseline blood work drawn, and then you can go ahead and start this. Because once they make the decision to start, I think they want to start. I use the analogy of, like, say I'm shopping in Nordstrom and I find an amazing pair of shoes that I really, really want. I want to wear them out of the store. And they say, we don't have your size here in the store, but we can mail them to you and you'll get them in a week. I immediately become less excited because I want to wear those shoes out of the store for us. And so I view that as equivalent to giving a few samples for patients to start so that they can get started on the therapy that they have chosen.
And last question before we wrap up, what do you do if a patient comes in on the treatment and gets COVID or other diseases or other infections? Would you stop them?
That's a really good question. I don't think there's one right answer to this question. You're probably going to get several different answers from several different people. My thought process is, I don't think I would stop it, because there is even an oral JAK inhibitor that's approved to treat COVID. Baricitinib is actually approved down to the age of 2 to treat COVID. Sabinco, of course, is not. But still, these JAK inhibitors has been studied not only in the setting of COVID, but is actually a therapy for COVID. So I don't think I would stop it. The one nice thing is, if there is a reason that you feel like your patient should stop their oral JAK inhibitor, it's out of their system very quickly. The half-life for Sabinco is 3 to 5 hours. So if there is a situation where you need it out and you need it out rapidly, the JAK inhibitors, they go away very quickly.
Wonderful. Well, perfect. Thank you so much, Lisa. Thank you for our attendees for being here. This was an excellent evening. Roxanne, I will hand you the virtual mic back. And have a great night, everybody. Happy holidays.
So thank you again to our supporter, Pfizer, for making this educational event possible. And also stay tuned. This is the end of this webinar. And also stay tuned for this Thursday when we have Dr. Brad Glick, who is going to be talking to us about Bimzelx and a transformative results in hidradenitis suppurativa. So thank you again, everybody, for joining us. We appreciate it. Good night.